Dr. Michael Connery is one of our nephrology and critical care attendings who will be speaking to us about blood pressure targets in critical illness.
All right. Well, hope this mic is working. Thank you again to the organizing committee and Dr. Fisher and everybody for inviting me back. For those of you who were here last year, I'm not going to have any costume changes this year, so hopefully you'll be spared with some of that. All right, so I was asked to talk about blood pressure targets in critical illness, and this is hopefully a topic that is important to everybody in terms of what are we supposed to actually be doing. So here are my disclosures. None of them are relevant to this talk, and importantly, my wife, who's also on faculty, has no relevant disclosures for this talk. So we're going to try a question. 54-year-old female presents with shortness of breath and depressed mental status. Heart rate is 124. Blood pressure 60/30. Stats are 80. She's tachypnic. She's in respiratory distress. The chest X-ray shows multifocal infiltrates. Lactate is high. She gets, in no particular order here, okay, intubated, cultures collected, 4 liters of plasma and antibiotics are all given, and she started on norepi at 0.2 mics per kilo per minute. So the question for you is, what is the target for hemodynamic support and resuscitation over the next 12 to 24 hours? A MAP of greater than 65, a MAP of greater than 80, a lactate less than 2, mean perfusion pressure of greater than 60, an SCVO2 of greater than 70, or to maximize the volume status of the patient. So can we go forward now? Let's see if it works. Okay. Whoa. Oh, some others have gotten in. Okay. Good. All right. Well, it seems like most people think that the target should be a MAP of 65. So let's talk about that as we go. Okay. This is not really a right or wrong answer, but this is a poll. So that's what most people think. So I guess, can we keep moving? Okay. The person who says maximize volume status needs to meet me outside later. All right, so today we're going to review a few things. I want you to be able to talk about some of the physiology of blood pressure. I want you to be able to describe some of the differences between blood pressure and blood flow and understand the concept of perfusion pressures overall. All right, so I'm going to give you the take-home points up front. So in case you want coffee or to go to the bathroom, you can just walk out after this. The take-home points is pressure does not equal flow, okay? And that the goal is organ perfusion. All right? So let's talk about the history of blood pressure. This guy is William Harvey. He was a scientist in the late 1500s, early 1600s. He was the first to really describe blood circulation. Everyone knew from way back in Greece, that there was a heart and it pumps, but exactly what it was doing wasn't quite clear. And then, believe it or not, this guy was the first known person to measure blood pressure. He was actually a clergyman, and he was involved in a lot of different scientific ventures. He wasn't a physician. He measured blood pressure in a horse by holding the horse down and jabbing his carotid artery and connecting it to a glass tube and measuring how high the blood went up. So I figured I did not want to demonstrate that for you here today. I figured you didn't want to see that necessarily. And good thing it's advanced since then. And then in the late 1800s, the sphygmomanometer was developed, and Korotkov sort of improved upon the technique and described the Korotkov sounds of the systolic blood pressure and the diastolic blood pressure that we talk about. But as early as the 1850s, there was already a recognition that hypertension or high blood pressure was somehow related to cardiac problems and kidney disease, even though they didn't know much more about it at that point. So what is blood pressure? Blood pressure is cardiac output times systemic vascular resistance. That's the equation. Okay, that's what determines what our blood pressure is. And there's a lot of factors that contribute to blood pressure. I'm not going to go through all of these in great details, but both the brain, stimulates the heart, it stimulates the peripheral vasculature, the kidney retains salt, retains water, the adrenal glands contribute angiotensin II, norepinephrine, epinephrine, and other sorts of corticosteroids and mineralocorticoids that stimulate kidney function and other vasomotor tone. So it's a very complicated system of determining what systemic vascular resistance is, as well as cardiac output. And those two things together is what drives our blood pressure. So blood pressure is cardiac output times systemic vascular resistance. Mean arterial pressure is cardiac output times your systemic vascular resistance plus your CVP. Okay? And that's what mean arterial pressure is. Now, we can't necessarily always figure that out. So let me show you how mean arterial pressure is calculated in real life. Okay? You've probably all seen this formula, which is that your estimated, not your true, but your estimated mean arterial pressure is 2/3 of your diastolic pressure plus 1/3 of your systolic pressure. You can estimate it also by taking your diastolic blood pressure plus 1/3 of your pulse pressure, so your difference between your systolic and your diastolic. The problem is that this classic formula only holds true if your heart rate's less than 60, okay, or around 60. As your heart rate goes up, your diastolic time goes down, and so this relationship doesn't necessarily hold true, and this becomes the equation. So who can do this one for me in your head on rounds? Because I'll ask you tomorrow. Okay? I can't, so better be ready. Now, the modern telemetry monitors actually do a more complicated thing. Most of them, I'm not going to get into which brands do what, but most of them actually calculate mean arterial pressure by integrating the area under the curve of the arterial pressure waveform when you have an art line in place. And then they divide that by the duration of the cardiac cycle that it's measuring on a beat by beat or every couple of beat measurements. So it's a bit more accurate on the modern telemetry monitors when you're using an art line. It's not necessarily an estimated number. So what is the goal target map then in critical illness? This is another question. Whoops, it skipped past there. Okay. All right, so most people say MAP is 65. It's mirroring our original poll, so that's good. People were consistent with their answers. All right, let's keep moving. All right, so MAP targets in critical illness. So these were sort of established a while ago based on the fact that it seems like in normal people, autoregulation of flow to organs falters below a MAP of 60 to 65. So Dr. Radcliffe's brain and my kidneys auto-regulate nicely as blood pressure decreases to try to maintain blood flow. Historical sepsis guidelines going back a long time recommend a MAP of greater than 60 to 65, and these were really based on very small studies of less than a total number of 500 patients across multiple different studies, and it was a mix of retrospective and prospective studies. And what these studies showed was that increasing MAP above these targets did not yield any improvement in survival or organ function. Okay? And so because of these studies in the late 80s and early 90s, this is where this MAP of 60 to 65 comes from. So this is an interesting trial, huge trial that looked at thousands of patients from a Cerner database published in 2018, looking at the relationship between ICU, hypotension, and mortality in patients with septic shock. And thankfully, they did confirm that more time spent below a MAP of 65 increased someone's risk for AKI, and more time spent between a MAP of 65 increases people's risk of death. Okay? So a MAP of 65 does seem, at least in confirmatory large trials done more recently, looking retrospectively at least, that a MAP of 65 sort of seems to be a floor below which survival and mortality seems to go, mortality goes up and survival goes down. Okay? But this trial also showed that it's not the whole story, because they also showed that fairly consistently, as MAP goes up, survival goes better. Okay? And AKI rates go down. And MI rates go down. All right? Now, this is in contrast to a study published in 2014 that was mean arterial pressure versus, that looked at different mean arterial pressure targets in septic shock, and was a randomized controlled trial of low MAP versus high MAP in septic shock. And they did an excellent job separating their two groups in terms of the effect intervention. And they really showed no difference in all comers. But you all know, from many of you have seen this trial before, and know that there is a lot of secondary analyses of this study that suggests that maybe this doesn't tell the whole picture either, that patients who have chronic hypertension or patients who have CKD or other things might benefit from higher MAPs when looked at in this group. And there was a similar trial published right around the same time or a year later that looked at this and again showed very similar results based on mean arterial pressure. But the question is what's the relationship between blood pressure and flow? If I told you already that blood pressure or pressure does not equal flow, then what is the relationship? So as our heart squeezes every time, we get both a pressure wave and a flow wave that travels down our arteries, okay? The pressure wave, the pulse that you feel, travels 20 times faster, or about 10 meters per second, down the vasculature. The pulse, the actual flow wave, arrives several seconds later and travels around 0.5 meters per second, okay? So you feel the pulse before you feel the cardiac output or the actual arrival of the flow. That's important. And when we have situations where we have decreased or increased resistance or impedance within the systemic vascular resistance, there are some really important changes that occur to this pressure-flow relationship. So when we have a sick heart, and therefore we have potentially a low cardiac output, high systemic vascular resistance sort of state, what happens to the pressure wave and the flow wave? The speed of the pressure wave is actually increased greatly, okay? Because the vessels are stiff. But the speed of the flow wave is actually decreased greatly, okay? So the flow wave arrives a lot later in this situation. And what happens in sepsis where you have a vasodilatory sort of state? The pressure wave, the speed and the magnitude of the pressure wave will be decreased, okay? But the flow wave, the speed and the volume of blood delivered is actually increased in that situation, all right? So when we have abnormal vascular resistance or impedance in critical illness, arterial pressure is not necessarily a reliable index of blood flow. And we use it like that a lot of times. And I think we need to be careful to hang our hat on a single number. I'm happy because my patient's MAP is 70. All right? Because a MAP of 70 should not reassure you that blood flow and blood delivery is acceptable. So remember, pressure doesn't equal flow. And I would argue that blood pressure is not the goal of resuscitation. The goal is cardiac output and blood flow, all right? So the good news is that the relationship between blood flow and blood pressure in terms of what determines it is very similar. That blood flow is also determined by cardiac output and systemic vascular resistance, which is why in healthy people, blood pressure can oftentimes be a good surrogate for blood flow. But cardiac output is determined both by preload, it's determined by stroke volume. I unfortunately neglected to mention here RV function, but I'm a huge RV type of supporter. So LV and RV, end diastolic volume, and contractility determines stroke volume. And then heart rate, okay? For those of you who work in cardiac ICUs, how many of you have been in situations where patients seem to have an adequate stroke volume, but their sick heart has a low heart rate, and therefore their cardiac output isn't very good, and we have to automatically sort of pace them at a higher rate to try to augment cardiac output, okay? Afterload also determines stroke volume, and afterload is determined primarily by systemic vascular resistance. But systemic vascular resistance is also determined by your artery constriction and dilation, your various compartmental pressures, your venous capacitance and pressures, and all of these things are not necessarily factored in when we look at MAP, okay? So let's talk about that and why that's important. So this is a meta-analysis. I'm not going to get into the great details of this, but this is a meta-analysis that looked at a whole ton of surgery trials that looked at early goal-directed therapy around major surgeries. In other words, surgeries where people were going to require resuscitation and end up in Dr. Danner's ICU or Mary Still's ICU and need resuscitation. And what they showed in this meta-analysis was that in surgery patients, systematic goal-directed resuscitation and management was only beneficial when that systematic management automatically included inotrope support. Okay? So just maintaining blood pressure and filling preload with pressors and volume did not necessarily improve outcomes. It was the addition of inotropes and additional cardiac output that seemed to help patients. And then we have a lot of compartments in the body that can affect organ perfusion. So one that I am very interested in, and that we've talked about at this conference before with other presenters, is intra-abdominal pressure. Intra-abdominal pressure is the steady state of pressure that's inside your abdomen. And as intra-abdominal pressure goes up, you get a whole series of really significantly negative effects on both the heart, the lungs, the kidney, the abdomen, the brain, okay? And as increasing intra-abdominal pressure goes up, you get decreased renal artery blood flow, you get renal venous congestion, and that has really negative effects on the kidney function, causing oliguria, and I'll explain that again in just a couple of minutes. And so intra-abdominal pressure can really impact organ perfusion even if you have an acceptable mean arterial blood pressure. So intra-abdominal pressures are defined as an intra-abdominal hypertension is defined as a pressure greater than 12. Abdominal compartment syndrome is a pressure greater than 20 with new end organ dysfunction. And just to soothe the naysayers, you don't need to be paralyzed to measure this. And just because you have abdominal compartment syndrome doesn't mean that you need to have a decompressive laparotomy, okay? We know for sure that intra-abdominal hypertension is consistently associated with higher ICU mortality across many, many studies. And this is an extremely common problem. It affects 50% of patients in the ICU. Guess what else affects 50% of patients in the ICU? Acute kidney injury. That can't be a coincidence, okay? These two things are two of the most common things that you see in your ICU all the time, and we may not necessarily be checking for intra-abdominal pressure as frequently as we should. And there is a direct correlation between volume status and intra-abdominal hypertension. So as we expand volume, intra-abdominal pressure goes up. And as we increase CVP, intra-abdominal pressure goes up. And we know that abdominal compartment syndrome is a huge cause of acute kidney injury, undoubtedly. We also know that intra-abdominal hypertension in the setting of shock, so in other words, someone's hypotensive and they have a little bit of increased intra-abdominal pressure, that's also strongly associated with progressive AKI in many different studies. Why does this happen? Well, I already told you that you affect arterial blood flow potentially into here by raising intra-abdominal pressure. So if you raise intra-abdominal pressure and you don't have good mean arterial pressure or good flow, you can't necessarily overcome that and you choke off arterial blood flow. But there's another really important thing is that as you increase intra-abdominal pressure, you compress the IVC further, and that raises venous pressure inside the IVC, which means that you raise your venous pressure inside your renal vein. That leads to interstitial edema of an encapsulated organ, i.e. similar to the brain, and the kidney starts getting compressed everywhere, just like the ventricles get compressed. And when that happens, you lose filtration gradient across the liver glomerulus. And even if you have normal kidney function, your kidney is no longer able to make urine because there's no pressure gradient across the glomerulus. Okay? And it causes AKI. So venous hypertension, low abdominal perfusion pressure, both cause significant problems with AKI. The goal for abdominal perfusion pressure is maintaining an abdominal perfusion pressure greater than 60. That's what's recommended. Abdominal perfusion pressure is MAP minus intra-abdominal pressure. But I will tell you that to date there's no published prospective randomized controlled trials that look at this as to whether or not maintaining abdominal perfusion pressure actually improves outcomes. Okay? What about cerebral perfusion pressure? So cerebral perfusion pressure is a very controversial topic. I think Dr. Radcliffe might throw some things at me. It's a very controversial topic, but for years and years we talked about maintaining cerebral perfusion pressure, and cerebral perfusion pressure is MAP minus intracranial pressure. If the CVP is greater than, if the CVP or jugular venous pressure is less than ICP, and if the JVP is very high, greater than ICP, then it's MAP minus JVP. The cited goal is 60 to 70. And unfortunately, we have no or contradictory data that, about this, and whether this is just a surrogate for bad outcomes or causative is not clear. Okay? There's also in the ER a lot of discussion about something called coronary perfusion pressure, especially during CPR, which is diastolic blood pressure minus LV end diastolic pressure. And that we know that patients who have a coronary perfusion pressure during CPR of greater than 15 have a much higher rate of achieving ROSC. Okay? So perfusion pressures in different compartments are very important. Okay? And perfusion pressure doesn't necessarily purely reflect mean arterial pressure, right? It's mean arterial pressure plus some other component that affects your actual true perfusion pressure. What are other options that are out there? A lot of people are starting to look at something called your mean perfusion pressure, which is your MAP minus your CVP. And that flow to organs must factor in venous pressure. And the reason for this is that if venous pressure is very high, blood can't get out of the organ. And if the blood can't really get out of the organ as well, if there's afterload to drainage from the kidneys, then the kidney gets edematous, like I told you before, and you get loss of your filtration gradient. It doesn't matter how good your inflow is if your outflow is stuck. Okay? Think about your house and your plumbing. All right? If your toilet is stuck, it doesn't matter how many times you flush it, eventually it's going to overfill, right? Okay. So, and there have been a few studies that have looked at this. One study from a colleague of mine that I work with named Marlies Osterman in the UK. That's not projecting very well, I'm sorry. But she found that each 1 point increase in mean perfusion pressure above 60 for patients decreased the progression of AKI by about 4.5%. Okay? So if you have a mean perfusion pressure of 65, your risk of AKI and progression of AKI was decreased. Another study has looked at this in a retrospective sort of fashion, a bit of an observational cohort, and they showed that they were using a much more complicated thing called mean perfusion deficit. So how long did you have your mean perfusion pressure less than 60? How many hours of a deficit did you have? And the more hours of a deficit you had, the much higher rate of AKI was noticed. So in conclusion, I'm not going to give you any fantastic answers here as to what's best, okay? But MAP alone should not reassure you that everything is okay. We need to be capable clinicians who integrate multiple streams of data to assess the flow and perfusion of our patient, okay? What is the urine output doing? What's the renal function doing? What's the mental status, the skin temperature, the cap refill, the lactate clearance, the SCVO2? All of these things need to be looked at to determine, okay, my patient has a MAP of 70. Are they otherwise doing okay? All right? We can't just look at the MAP. And optimal cardiac output is very difficult to define. So it's hard for us to do studies on this because what one person needs in a critical state might be very different from what somebody else needs in terms of cardiac output perspective. And those needs change over time. So what I would recommend is that you really need to individualize your hemodynamic targets. You should consider checking intra-abdominal pressure to assess abdominal perfusion pressure. You should have a low threshold for inotrope support. Even if someone has a good EF on echo, that doesn't necessarily mean they have an adequate cardiac output for their critical illness. Okay? And I hear this all the time respectfully from cardiology colleagues who come by and say, oh, this patient's EF looks good on echo, get rid of the dobutamine. That's not necessarily true that everything is okay with cardiac output. and that while mean pressure of 65 or 70 might be a reasonable initial target during resuscitation, we should view that number with caution in the maintenance phase of critical illness. So when patients are stuck on pressors for several days, you may need to view that number with caution, okay? It's reasonable in the first few hours. And more research is needed, so we need to collaborate. We are doing currently an NIH-funded study in collaboration with a couple of other centers and a manufacturer of a catheter, where we are randomizing patients at Grady with septic shock and raised intra-abdominal pressure to standard MAP targets versus a dynamic MAP target that changes in order to keep the abdominal perfusion pressure greater than 60. And our primary endpoint on this is going to be renal function at day 7, and hopefully I can tell you in a few years what this will show. You're welcome to join our team if you want. We need help. Okay, so in conclusion, pressure does not equal flow, and the goal is organ perfusion. So we need to ensure that while we have an acceptable blood pressure, that we actually have acceptable blood flow to all of the organs. And we need to potentially individualize care in that situation. So if I have time left, I will take a few questions. Otherwise, thank you very much.